Hello students, welcome to chapter 21, which focuses on the respiratory system. I'm going to give you the lectures completely online. We'll do like a series of probably about 20-30 minute lectures until we get to the end of the chapter, and then in class on Tuesday night we will do some practice questions and then move on probably more than likely to the urinary system, unless there's some confusions about the respiratory system that you guys want to go over, in which case we can definitely go over anything that confuses you. That's why we do practice questions, right? All right, so when we're talking about the respiratory system, the anatomy is actually not super complicated, and the physiology is more complicated than the anatomy, but a whole lot less complicated than the cardiovascular physiology. So if you felt good with cardiovascular stuff, you should be just fine with the respiratory system. The whole purpose of the respiratory system is a process that we call respiration. We want to give our body oxygen because we require oxygen in order to carry out aerobic respiration, which is how most of the cells of our body make ATP. And as a byproduct of that process of aerobic cellular respiration, CO2 gets made, but our body can't use CO2. It's just a waste product for us. And so we have to have a way of getting rid of it. And our respiratory system is what does that. It exchanges oxygen for carbon dioxide so we can get rid of the carbon dioxide. The respiratory system also plays a role in olfaction, smell. Our olfactory receptors are in the nasal cavity, and also speech. We're going to talk about kind of vocal production in a little bit, but that's due to some of the structures in our larynx. So the respiratory system does have a couple other kind of accessory functions, but its prime purpose is respiration and the exchange of oxygen for carbon dioxide, carbon dioxide for oxygen. So in terms of the processes that we're going to look at, there are two processes that are carried out by the respiratory system, and then two processes that are carried out actually by the circulatory system, not the respiratory system, although we're going to learn about them here in the respiratory system chapter. So the first process that we'll discuss is pulmonary ventilation, and that is the air moving in and out of your lungs, the actual physical act of breathing. And that actually has very simple mechanics. In fact, so simple it kind of blows my mind a little. And that is carried out by your respiratory system. The second process that we'll look at is external respiration. And this is the exchange of oxygen and carbon dioxide that takes place between your lung tissue, your alveoli, and the capillaries around your lungs. So we pick up oxygen from the environment and we exhale CO2 to the environment. That's external respiration. Once we have that oxygen, or once our cells of our body have made CO2 as a waste product, we have to have a way of transporting it, right? And of course for us that's in our blood. So we're going to talk about how oxygen and carbon dioxide are moved through the body, through the blood. And we all will also talk about internal respiration. And like external respiration, it's an exchange of oxygen and carbon dioxide, but now not in our lungs, but in all of our systemic tissues. So the oxygen gets dropped off at the tissue so the tissue can use it, and the CO2 moves out of the tissue so it can make its way to the lungs to be expired and gotten rid of. So that's kind of where we're headed. But before we get to that, we're going to discuss a little bit of kind of anatomy of the respiratory system. We basically break the respiratory system into an upper respiratory system and a lower respiratory system. The upper respiratory system consists of the nose and nasal cavity, the nasal sinuses around the nose, which always gets so congested when you're all congested due to allergies, the pharynx, which is the anatomical term for throat, and then the lower respiratory system is the larynx, it's where your voice box is, the trachea, which then divides into the bronchi, which go actually into the lungs. The bronchi divide many times once they're in the lungs, and we're going to look at that as well. And then, of course, the lungs and then the alveoli in the lungs are also part of the lower respiratory system. So if we were to look at a figure of that, you can see here's your nose and nasal cavity, down through the throat, the pharynx, and then, so that's all upper respiratory system. And then lower respiratory system, the larynx, the trachea, and then you can see the trachea divides into the bronchi lead into the lungs, and once they're in the lungs, the bronchi then branch multiple times, as we'll see in just a little bit. So we're going to start with the nose and nasal cavity. It is the airway. It's how we breathe in for most of us. It's lined with a nice mucosa that makes the air nice and kind of humid and warm, also acts like a filter. We don't want really cold, dry air reaching our lungs, so the nasal mucosa helps with that. It also acts as a resonance chamber, so when you speak, your words resonate more, and at the very roof of your nasal cavity, you will find your olfactory receptors for your sense of smell. So just kind of behind the kind of external nose, what we think of as the nose, is the nasal cavity. It is divided by a septum, so it's kind of a right nasal cavity and a left nasal cavity. And actually just above our nostrils, just inside the nasal cavity, it's what we call the vestibule of the nasal cavity, and it actually has vibrissae, which are the anatomical term for hair, and that helps kind of filter some of those particles from the air that we breathe in so that they don't get back down into our lungs. So that's what we're talking about when people have those, I've seen people with the crazy nose hairs, right? That's the vibrissae, and they do actually have a purpose. As I mentioned, at the roof of the nasal cavity, that is where we find our olfactory mucosa and our olfactory epithelium. So all of our sensory receptors for smell are right up there at the roof of the nasal cavity, which of course is why when we smell something good, we take a nice inhale through our nose, nice cookies baking or something like that. All of the nasal cavity is lined with a mucous membrane, a mucosal membrane. It is pseudostratified ciliated columnar epithelium, so it's got lots of cilia. There are cells embedded in the epithelium that secrete some lysosomal and defensin enzymes, which act as an immune function. The cilia that lines all of the mucosa, because all this mucus gets made by the different cells in the epithelium, in the mucosa. Sometimes the stuff that we inhale that's not so good for us kind of gets trapped in all that mucus, and then the cilia kind of move back and forth to push that mucus to our throat so we can swallow it, as opposed to having it go down our lungs. There's a ton of capillary networks, a ton of veins in and around kind of around the nasal cavity and in and around the tissues of the nasal cavity. And since our blood is warm because it's body temperature, that is what warms the air that we breathe in, so that we're not getting kind of cool air going into our body. It's already at our body temperature by the time it reaches our lungs. There are lots of nerve endings in the respiratory mucosa. It helps trigger some of those sneezing reflexes, and again, it's mostly to get stuff out. Because of the way the mucosa is designed, the fact that we get the filtering, the moistening, the humidifying, and all of that warming. So it's really so that no cold, dry air reaches the alveoli, because the alveoli are much more fragile than just about anything else in the lungs. You'll also see when you look at the nasal cavity what we call the nasal conchae, and they're basically these projections that kind of stick out from the walls of the nasal cavity. There's 3 of them. There's a superior, middle, and inferior concha, and then a groove called the nasal meatus that runs underneath of them. And the whole purpose of these things is basically to increase the amount of surface area for that mucosa, so that way we can really get nice, humid, warm air coming down into our lungs. The air, when it hits these nasal conchae, doesn't flow like smoothly. It becomes kind of more turbulent and mixes, and it basically just kind of slows down the flow of the air so that the air kind of stays in the nasal cavity and can really be warmed and humidified before it kind of makes its way out of the nasal cavity. And I'll show you a figure in just a second. Of course, on either side of the nose, right above the nose, and in the cheeks, we'll find our nasal sinuses, our paranasal sinuses. Again, this is what gets kind of clogged whenever you're like, oh, I have a sinus infection. It's usually because some sort of bacteria or something has gotten into these paranasal sinuses. A sinus is really just an empty space. It is lined with mucosa, but because you have some of these empty spaces, it kind of just helps lighten the load of your skull. They do secrete mucus because they are lined with epithelium, and that's of course what gets kind of traps the bacteria sometimes when we end up with those sinus infections, and also contributes to kind of warming and humidifying our air. So the frontal sinus is right up here on the forehead. You have the ethmoidal sinus and the sphenoidal sinuses kind of right here on the bridge of the nose, and then the two maxillary sinuses kind of over the cheekbones. And all together they kind of carry off the same kind of function. If we look at the pharynx, what we're talking about is the throat. That's the anatomical term for throat. So it connects your nasal cavity and also your mouth to the larynx and the trachea and esophagus. It is skeletal muscle, and it's divided into three parts. The nasopharynx is behind the nose. It is a passageway purely for air. The oropharynx is behind the oral cavity, behind the mouth, and it is a passageway for both air and food, because when we swallow our food, it comes down here. And then the laryngopharynx is a passageway for air and food as well. Food will go down the esophagus, and the air will then go down the trachea here. And that's the path that we're going to follow in terms of the respiratory tract. So just to point out a couple of the things that we've discussed thus far in terms of anatomy, you'll see here's your nostril leading into your nose. Here's the little vestibule where we have the nose hairs. These are the nasal conchae, these kind of projections that hang out from the wall that increase the surface area, make the airflow more turbulent. You can see the little grooves underneath them that are the nasal meatuses. And then if we look at our pharynx, we've got nasopharynx, oropharynx, and laryngopharynx. You can see here's the sphenoidal sinus, here's the frontal sinus, and I think that's all you can see on this one. You can see also hard palate, soft palate, separates the nasal cavity from the oral cavity. There's your tongue and your oral cavity. We'll talk about that when we get to the digestive system. And then you'll see all the different parts of the larynx here, and we're going to talk about the larynx in just a second. It does open from the laryngopharynx and then connects basically the laryngopharynx with the trachea. And the larynx has three functions. It helps keep our airway open. That's what we call patent. It also helps get air and food kind of into the proper chute, and then it houses our vocal cords. So our voice comes from our larynx. This is what the larynx looks like kind of exteriorly if we were looking at it anteriorly, like head on. This is the thyroid cartilage, and in fact that Adam's apple that's so prominent on men is part of the thyroid cartilage. The cricoid cartilage is down here, and then to see the other ones you really kind of have to turn it on its side. So now that we're looking at it in a sagittal view as opposed to in an anterior view, again you can see here's the cricoid cartilage and the thyroid cartilage. There are several different ligaments that help attach this thing all together. There's cuneiform cartilages that are paired, corniculate cartilages that are paired, the arytenoid cartilages. All of these structures are paired kind of right and left. But I also want you to pay attention to these folds here. So the vestibular fold is this one at the top. It's a false vocal cord. The vocal fold is this fold here. It's actually the true vocal cord. And then this kind of space, this slot between them is called the glottis. You'll also see that we have this kind of big piece of cartilage here. All of these other cartilages are hyaline cartilage. The exception to that is this cartilage here, which is the epiglottis. And the epiglottis essentially shuts down over your trachea when you swallow, so that food, let me go back for a second. Here's again the epiglottis. It'll shut down over the trachea here when you swallow food, so that food goes down the esophagus and not your trachea. As I said, we actually have two folds in the larynx. We have true vocal folds, which are the vocal folds, the true vocal cords that actually are responsible for the production of your voice. The glottis is kind of the opening between them. And as air moves up from the lungs, that vibrates those folds, and that's what actually produces the sound that we think of as our voice. The vestibular folds are on top of the vocal folds, and they don't actually play a part in the production of our voice, but they do help to close the glottis, the space there when we swallow. So again, just kind of reinforcing that we don't want food going down the trachea. In terms of voice production, it really is the air that we breathe out as we open and close the glottis, and as those vocal cords kind of vibrate, that's how we get our voice. That's how we're able to produce sound, to talk or sing or laugh or whatever the case may be. The pitch of our voice is determined by the length and the tension in the vocal cords. The loudness of our voice is actually how much force we put behind it. If we speak very softly, then it's not a very forceful outflow of air. If we're speaking very loudly, it's a very forceful outflow of air. All of the kind of cavities in the throat and the oral cavities, nasal cavities, they basically just amplify all of that sound. And then to actually shape our sound into a language, into song, it's all of the muscles up there. We've got muscles in the throat, we've got the tongue, it's a big old skeletal muscle, we've got muscles in the soft palate, the lips are a muscle, and all of that then takes this sound, which really just waves produced by the shaking of the vocal cords, and actually turning it into language. And that's a pretty neat thing, I think. So once we're past the larynx, we're then now into the trachea. And so the trachea descends all the way down kind of into the thorax and then divides into the two main bronchi that lead into the right and left lungs. The trachea has 3 layers in terms of its wall structure. You'll see it has a mucosa of pseudostratified columnar epithelium, also still ciliated, so just like our respiratory mucosa. There's the submucosa underneath, which is connective tissue, also has lots of glands here in the submucosa that are producing a lot of this mucus. And then you'll see some hyaline cartilage, and if you look at the hyaline cartilage, you'll see it's a little C-shaped ring. This C-shaped cartilage ring is what we call, again, this idea of patency. We want our airway to stay open all of the time. The esophagus, which is posterior to the trachea, doesn't have that cartilage, and so the esophagus tends to smoosh in on itself and not stay open, and only really kind of opens widely when we swallow food. And then just past the hyaline cartilage ring, we'll get a little connective tissue adventitia, just to kind of keep the whole thing together and keep it nice and tight together. Once we are out of the trachea, as I said, the trachea divide into what we call the main bronchi, or the primary bronchi. We have one that goes to the right lung, one that goes to the left lung. The main bronchi then branch into what we call lobar or secondary bronchi. The secondary bronchi then branch again into what we call segmental and tertiary bronchi. And then those bronchi branch even more into what we call bronchioles, and the bronchioles basically get smaller and smaller and smaller and smaller until we call them terminal bronchioles, which then branch even further into the respiratory bronchioles, which lead into the alveolar ducts that go to the alveolar sacs, and in those sacs of alveoli we have the actual alveoli where gas exchange takes place. So essentially, from the time we breathe the air in, it's going to go all through the nasal cavity, the pharynx, the larynx, and then through the primary, secondary, tertiary bronchi into the bronchioles. And that's really it. Like, these are just what we call conducting zone structures. They're not doing anything beyond moving the air. Once we get into the terminal bronchioles and the respiratory bronchioles, and in particular the alveoli, those are our respiratory zone structures. And it is really the alveoli in particular where gas exchange is going to take place. So very often we'll call this kind of branching of the bronchi into the bronchioles and so on and so forth the bronchial tree, because if you look at it, it kind of looks like a tree, right? Upside down one anyway. So here's our trachea dividing into the right and left bronchi, and then the primary bronchi branch into the secondary bronchi. The secondary bronchi then branch into the tertiary bronchi, which then branch into the bronchioles, getting kind of smaller and smaller and smaller until we finally end up at the terminal bronchioles, the respiratory bronchioles, which lead into these sacs of alveoli. And the alveoli, as you can see, very, very microscopic, tiny things, are where the gas exchange actually takes place. Simple squamous epithelium, very thin walls, so oxygen and carbon dioxide can just diffuse very easily. When we look at where that diffusion takes place, it's across what we call the respiratory membrane. And it's basically a barrier of where the blood, the capillaries that are all surrounding all of these alveoli meet the alveoli. And in fact, their basement membranes will actually fuse so that the alveoli and the capillary walls are actually kind of stuck together. And you can see they're very, very, very thin, not even a half a micron. So they're very, very thin walls. So it really is just a matter of simple diffusion that'll allow oxygen and carbon dioxide to be exchanged. The alveoli themselves have kind of two parts, at least their walls do. The simple squamous epithelium is what we call type 1 alveolar cells, and that's really what makes up kind of the main wall of each alveolus. But kind of scattered in amongst these alveolar walls, we'll find type 2 alveolar cells. They're cuboidal, not squamous, and their main purpose is to secrete something called surfactant, which is a detergent-like substance that we're going to talk about in another lecture. So here we go. You can see both in the micrograph here and in the diagram, you can see each of the little kind of grape-like alveoli, and you can see they're just completely and utterly covered in capillaries. So just completely encased and surrounded by these capillaries where all this exchange is occurring. So it's going to move out of the alveoli into the blood if we're talking about oxygen, and then from the blood into the alveoli if we're talking about carbon dioxide. So here you can see again, here's the exchange of oxygen and carbon dioxide, oxygen into the blood, carbon dioxide into the alveoli. You can see here's your respiratory membrane. It has been fused basically between the capillary and the alveolus. Here are your type 1 alveolar cells that again make up the kind of wall of the alveolus, with these kind of scattered type 2 alveolar cells that secrete surfactant. In terms of kind of gross anatomy of the lungs, most of the lungs are pretty much nothing but alveoli, and what part of the lung isn't alveoli is what we call stroma, which is basically just a bunch of elastic connective tissue and other soft tissue. So it makes your lungs very elastic, very spongy. They have a really good ability to kind of stretch and recoil because of all that elastic tissue, and if you just breathe in and out, you can kind of feel your lungs kind of changing size, and that's due to that nice elasticity. The left lung has two lobes, so it has a superior and inferior lobe. Separating them is the oblique fissure. It is a little bit smaller than the right lung, in part because of the heart. So you'll notice that it'll have a little notch in it that is kind of the space for where the heart fits. The right lung has three lobes, superior, middle, and inferior lobe. So the superior and middle lobe are separated by a horizontal fissure, and then the middle and inferior lobes are separated by an oblique fissure. So here you go. Here you can see superior lobe of left lung, inferior lobe of left lung. You can see the little cardiac notch, and you can see the left lung is a little bit smaller. And then the three-lobed right lung, horizontal fissure, oblique fissure, and there's the oblique fissure of your left lung as well. In terms of blood supply to your lungs, the blood goes to the lungs in actually kind of two ways. Well, we have the pulmonary circulation, which is the circulation that we were talking about when we were talking about the pulmonary arteries and the pulmonary veins that take the blood, if we're talking about the pulmonary arteries, from the right side of the heart to the lungs to actually get oxygenated. So it's very low pressure, very high volume system because all of the blood of the body has to go to the lungs to get oxygenated. And then the pulmonary veins, of course, bring it back to the heart, so then the heart can then pump it out to all of the other body organs. But that blood being pumped out that's now nice and oxygenated by the lungs and being pumped out by the left side of the heart still has to go to the lungs itself in order for the lungs themselves to have oxygen in order to function. And that's what we call the bronchial circulation. The bronchial arteries branch off of the aorta and actually provide all of the oxygenated blood to the lung tissue so the lung tissue can carry out oxygenation of the blood. So this is part of the systemic circuit. It's very high pressure. It's no different than a blood supply to a muscle or something like that. The bronchial veins actually join up with the pulmonary veins, and then, as we've seen before, the pulmonary veins bring all the blood back to the heart. In terms of innervation of our lungs, we get both motor fibers and sensory fibers. The motor fibers are from the ANS, so parasympathetic stimulation causes bronchoconstriction, so the bronchioles get smaller. Sympathetic innervation causes dilation, so the bronchi and bronchioles get larger, which means we get more oxygen into the body. The sensory fibers are things for looking at kind of pH levels and oxygen levels and kind of irritant levels and a couple of kind of different sensations. And the nerves basically enter through what we call the pulmonary plexus at the root. So if I go back here for a second, so I think I have to go back. I don't think I have a figure for that. But essentially where the lungs kind of connect together is like the root of the lung. And so this is where the nerves come into the lungs and then kind of spread out and branch out through the rest of the tissue. The lungs do have a serosal membrane, so it's because they sit in the thoracic cavity. So just like the heart had a pericardium, two-layer serosal membrane, the lungs do as well. The parietal pleura actually lines the cavity of the lung, and then the visceral pleura actually then lines and adheres to the surface of the lung itself. Between the two layers of the serosa is our pleural cavity, and it is filled with fluid. This fluid makes the lungs kind of stick to the walls a little bit, makes it, provides a little bit of lubrication. So it just helps the lungs kind of expand and recoil as we breathe in and out more easily with a lot less friction. Okay, I think, no, let's continue on and get through pressure relationships and collapsed lungs, and then I'll stop and move on to a new lecture. So we have to kind of look at to talk about lung functioning, we have to talk about pressure dynamics in the thoracic cavity and kind of the different pressures that are in the thoracic cavity. All of the pressures that we talk about always have a reference point of atmospheric pressure, and that's essentially the pressure exerted by the air around your body. So just here we are in the room, in your house, that's the atmospheric pressure. And at sea level, it's 760 millimeters of mercury. We're not quite at sea level, but close enough to the point where it makes almost no difference. So when we talk about our respiratory pressures, we're always describing them in reference to atmospheric pressure. So if we have a negative respiratory pressure, then the pressure is less than atmospheric pressure. If we have a positive respiratory pressure, then the pressure is higher than atmospheric pressure. And if we have a zero respiratory pressure, it means that it's equal to the atmospheric pressure. It's not that the pressure is zero, it's that it's 760 millimeters of mercury, which is equal to atmospheric pressure. So we have a couple different pressures that we have to talk about. The first of these is the intrapulmonary pressure. So intra means within, pulmonary means lungs, so within the lungs. That is the intrapulmonary pressure. We could even go even further and call it intraalveolar pressure and talk about the pressure inside each individual alveoli, but typically we use intrapulmonary pressure. And it will fluctuate as you breathe and will always eventually equalize with atmospheric pressure, as you'll see in the second lecture. Intrapleural pressure is the pressure inside that pleural cavity, so between the parietal pleura and the visceral pleura, in the cavity itself in which the lungs sit. It also fluctuates with our breathing, but should always be maintained as a negative pressure. So we have to keep our fluid level at the appropriate level. So any excess fluid that gets made gets pumped out by the lymphatic system. And if that doesn't happen, if for some reason we get some sort of fluid accumulation, then what we end up getting is a positive intrapleural pressure, and that leads to a lung collapse. And obviously lungs collapsing, not really a good thing for us. Okay, so we have two forces that actually promote lung collapse, and one force that tends to kind of promote lung expansion. And these kind of three forces, in terms of kind of balancing out each other, is what keeps our lungs at their proper size. So our two inward forces are the lungs' own kind of natural tendency to recoil. And because they have all that elastic tissue, the lungs kind of in whole always try to kind of go to their smallest size. All of the alveoli are surrounded by a little film of fluid, and that fluid has fairly high surface tension. And that surface tension on the alveoli also tend to try to reduce the alveoli to their kind of smallest size. But our chest wall is also very elastic, and that tends to enlarge the lungs, especially because they tend to stick almost to the chest cavity because of the serosal membranes. And so keeping our lungs at the proper size is a balance between these three forces. Okay, since we have two cavities, we have a pleural cavity and then we have a within lung cavity, so we have intrapulmonary pressure and intrapleural pressure, we can also have a difference between those, and that's what we call the transpulmonary pressure. It is the difference of the intrapulmonary pressure and the intrapleural pressure, and it is actually the pressure that actually keeps your lungs open. And so we always want to have a positive transpulmonary pressure. because you definitely want to keep your lung spaces open. So if we increase that pressure, we tend to increase our lungs size. And if the intrapulmonary pressure became equal to the intrapulmonary pressure, or if the intrapleural pressure became equal to atmospheric pressure and didn't maintain itself at a negative rate, then the lungs will collapse, and that's not something that we want to happen. So I got a nice little figure here. So here's your intrapleural pressure. It will always equalize with atmospheric pressure, so that's why we call it 0. Remember, that's 760 millimeters of mercury, equal to atmospheric pressure. The intrapleural pressure is the pressure in the pleural spaces. It must be maintained as a negative value, so less than atmospheric pressure. Usually it's about -4 less than atmospheric pressure. And then the transpulmonary pressure, the difference, 0 minus -4, is 4 millimeters of mercury. So we want a positive transpulmonary pressure, because that's what actually keeps the lung spaces open so that we can breathe, so that we can get oxygen. The problem that can occur sometimes is what we call atelectasis, and this is a lung collapse, and it happens usually in one of two ways. It will either be that the alveoli might collapse, maybe your bronchioles are full of mucus, maybe the alveoli got too full of fluid, and they'll collapse. But more often, lung collapse is usually due to something that we call a pneumothorax, which is air inside the pleural cavity. And it can occur in one of two ways. It can either occur because we've ruptured the parietal pleura and air is coming into the pleural cavity from the external environment, or we can rupture the visceral pleura, and in which case air then is coming out of the lungs and into the pleural cavity. If that happens, that kind of excess air in the pleural cavity essentially increases the pressure in the pleural cavity and kind of shrinks the lungs. I've got a figure here in just a second, you'll see what I mean. If we get a pneumothorax, we've got to get that excess air out of there. And so that's when they use the chest tubes, they suck the air out, and then once the pleurae have healed, they'll like reinflate your lung. Kind of neat. I'd love to watch one time. So here you go. Here is if we rupture the parietal pleura, so now air is coming in from the outside. Here is if we rupture the visceral pleura, where air is then coming from the lungs into the pleural spaces. And if that happens, we essentially change our pressure here in the pleural cavity, and we get all that excess pressure basically pushes against the lung and kind of shrinks the size of the lung. And that is definitely not something that we want to happen, because the ability for your lung like this to carry out gas exchange is much diminished as opposed to the way it should be in its healthy state. Okay, so that's where I'm going to stop with the first one. You can stay tuned for a second lecture where we're going to dive into some of the dynamics and processes of the respiratory system.